We were undocumented, we were poor, therefore uninsured, and had very few resources. My parents worked a series of jobs, including at nail salons, clothing factories, driving taxis, all the things. A very typical, I would say, immigrant story. Within a couple of years, my family was fortunate enough to attain some sort of, economic stability. And so this was the first professionally taken family picture for our family. And my parents were so proud that we could afford a professional photographer to take a picture of our family. And so this is my early elementary school years. Now, fast forward 40 plus years, and for the very first time, I took my own nuclear family back to Korea for the very first time last summer. Now, this is a span of less than one generation. And while, yes, through the blood, sweat, and tears of my parents, we were able to reach this point in our lives, I would say it was their effort and the systems and organizations that wrapped around our family that allowed us to achieve this amount of, I would say, social, financial stability and success. And so from the community organizations in Greenpoint, Brooklyn, which is where I grew up, that provided after-school services to the kids in the neighborhood, to the public health or public hospitals that were in the community, to the New York City public education system that I was fully engaged in for most of my formative years. All of these structural institutions and services and supports wrapped around my family to allow us to continue on this journey. Now, when I think about my professional training, this is a photo of Kings County Hospital. I did my medical training in SUNY Downstate, which is in Flatbush, Brooklyn. And part of our training was at this public hospital. And it's one of the largest in the country, Kings County Hospital. And then I went on to do my residency at NYU. And the training facility for NYU is Bellevue Hospital, which is the oldest public health hospital. And my professional journey at these public hospitals taught me that if we really want to measure the health of our population, we really need to think about the health of the population that's served within these hospitals and the supports and structures that exist in our public hospitals that are serving those that have the greatest need. Now, just this week, actually, 2 days ago, this week is just flying by. On Tuesday, I visited LA General Medical Center. So that's the public safety net hospital for Los Angeles. And at the ceiling of their historic building, I saw this. Now, there's two things I want to point out. I don't know if you all can see that, but that man on the left is supposed to be a physician that's holding a baby upside down. So I suspect that's, like the NRP version of what was done back in the day, right? And just like stimulate them until they breathe and you get all the fluid, out of their lungs because it's coming out their mouth. Okay, so we don't do that anymore. So that was interesting in and of itself. But the second thing is I'm going to read what it actually says here. It says, in health, there is liberty. Health is the first of all liberties. And happiness gives us the energy, which is the basis of health. And so I found that to be so profound because it emphasizes emotional, mental well-being, happiness, as allowing one to achieve health. And health being the root of liberty and freedom. Without physical health, emotional, mental health, you can't even engage. You can't do all the things that you would want to do with the freedoms that you have. And so I found this to be very, very compelling because it was within a hospital, emphasizing the power of the work that we do in hospitals to provide health, that allow families to then achieve freedom, liberties, happiness. Health being really foundational in families being able to reach those goals. And so hospitals are important. I would say birthing hospitals are very important. When we think about the population that we have the privilege of serving, it's nearly all pregnant people who deliver an infant and sometimes not. So this is data from 2021. In the US, shown here are characteristics of US births. And you can see that in the US, 98.6% of births occur in a healthcare setting. So we actually are serving nearly all of the birthing population and families in the US. Moreover, in the NICU, very important because in our country, we have an increasing percentage of infants that are being admitted to the NICU each year. Shown here are rates from 2016 to 2023. Back in 2016, 8.7% of all infants were admitted to a NICU, and in 2023, 9.8% were admitted, so about 10%, so rising rates. Now, if we do a deeper dive on who are the infants that end up in the NICU, here we see admission rates by race and ethnicity. Shown in the dark blue is 2016, in green is 2023. So, first point, very clearly racial ethnic inequities in which infants need ICU care. In 2023, over 13% of non-Hispanic Black infants were admitted to the NICU, compared to 9.4% of white infants, 8.9% Hispanic, 8.76% of our Asian population. Second point is, if you see the change from 2016 to 2023 of NICU admission rates, the greatest increase are in our Black, Native Hawaiian, and American Indian Alaska Native population. So not only is there a disparity in who gets into the NICU, but there's a disparity in change over time, such that the racial ethnic gap or inequity in the need for NICU has actually grown over time. So I highlight this because the NICU is a very special place. We have these infants and families have a prolonged hospitalization, and we have an overrepresentation of families that have greater need. And so it behooves us that it's our opportunity to then serve a population that's overrepresented in the NICU and also engage with them for a prolonged period of time. That doesn't necessarily happen in the well baby nursery or in other parts of the hospital, but in the NICU, it can and it does. And yet, for many of our families, we know that there are significant barriers to parental engagement. We know there are structural and systems level barriers. We know a wide array of social determinants of health certainly influence parents' ability to be at the bedside. Within the NICU, the way that we communicate, the way that we interact with our families also informs their presence and magnitude of engagement. And then families themselves are undergoing a tremendous amount of emotional and psychological stress and experience those barriers that likely prevent effective engagement with staff and infants in the NICU. And one of these barriers that I wanted to focus on, really, which is the point of this portion of my presentation, is family leave. Now, I have the Family and Medical Leave Act as a barrier. This is federal legislation. This is US legislation, and it's a barrier because I'm going to highlight why. So, federal legislation gives 12 weeks of unpaid job protected leave per year. And birthing people are eligible for leave if they have worked for their employer at least 12 months, at least 1250 hours over the past 12 months, and work at a location where the company employs 50 or more employees within 75 miles. Okay, some criteria. And then it says that time taken off work due to pregnancy complications can be counted against the 12 weeks of family and medical leave. So our families who have gone into preterm labor and are hospitalized in antepartum for a month, well, that just takes away 4 weeks from their 12 weeks of leave, and it's not even paid leave, okay? And then this is direct language from the legislation. FMLA is designed to help employees balance their work and family responsibilities by allowing them to take reasonable unpaid leave for certain family and medical reasons. It also seeks to accommodate the legitimate interests of employers and promote equal employment opportunity for men and women. Huh? Really? Like, when is unpaid leave reasonable? It's probably reasonable if you're extremely well-resourced and don't need income for 12 weeks. And that's not many of us. And then, is there really an equal employment opportunity for men and women? when women are the only ones that can actually biologically have the baby and then not get paid for having the baby for 12 weeks. So this is federal legislation, which is why I sort of state it as a barrier. But fortunately, here in the state of Colorado, we have the Family and Medical Leave Insurance Program that went live January of 2024, so about 2 years ago. And so our state solution allows Colorado workers to receive up to 12 weeks of paid leave to bond with a new child, including adopted and foster children, care for themselves if they have a serious health condition, care for a family member who has a serious health condition, make arrangements for a family member's military deployment, address the immediate safety needs and impact of domestic violence and or sexual assault. In addition, those who experience pregnancy or childbirth complications may receive an additional 4 weeks for a total of 16 weeks per year. Significant improvement over our federal legislation. Now, it's not perfect because our state legislation still has some criteria, eligibility criteria, but a significant improvement. Now, I am happy to report that for the very first time, we have some early data around the impact of this legislation, meaning in our state, who then takes paid leave. Now, I'm already running behind 3 minutes, so I'm going to kind of buzz through the data piece. And so the data that we analyzed, and this project is being led by Dr. Angie Shin, who's a pediatric resident, with oversight and programming by Blair Whiteville, our statistician. And we looked at data from the Baby and You survey. So this is a state perinatal surveillance system that lives within our CDPHE. Mothers who recently had a live birth are asked questions over the first 3 years of their infant and toddler's life. And so the data that I'm sharing with you are surveys that mothers completed about 3 to 4 months after having a baby in 2023 and 2024. And the question that's asked is whether or not they took paid leave. And so the denominator here is women who worked before or during pregnancy and then asked if they took paid leave. Now, this is not, is it full paid leave? Is it partial and for how many weeks? But any paid leave. And so what you can see here is that there's dramatic improvement in the percentage of new mothers that took paid leave. But you'll see that there's significant racial and ethnic disparities, that still there's a significant inequity in which groups take leave and which groups don't. And there's a difference in the magnitude of change from 2023 to 2024. Significant differences in age. Where we saw the greatest impact of the family leave legislation is in our young mothers, those less than 20, where a tiny fraction took leave in 2023 and 35% then took leave in 2024, but still far lower than our 35 plus population. So I'm going to buzz through here and talk about residents. Here we see paid leave uptake within the Denver area, other metro, and then in the rural regions. Yes, uptake improved for all, but still we see that there's a significant disparity between Denver and in our more rural communities. And so if we think about legislation that's passed at the state level, the uptake will still vary within our local communities. NICU admission. And so here we're looking at if you were admitted to the NICU or not, did you take leave in 2023 and 2024, paid leave that is. Again, both groups improve, but the rate of increase seems higher for those that did not have a baby in the NICU. And I would imagine many of us think that paid leave for families in the NICU is essential for families to be able to be at the bedside and then care for their infants after discharge. Now, that was family leave past January 2024. Amazingly, we have an update, and it's called the neonatal care leave kind of supplement to the family leave. And again, this was co-sponsored by Dr. Jeff Bridges. And this legislation states for claims arising on or after January 1st, 2026, so just a few months ago, an additional 12 weeks of paid leave are permitted I am losing my screen here, so I will read from here. For claims arising on or after January 1st, 2026, an additional 12 weeks of paid leave are permitted to a covered individual who has a child receiving inpatient care in a neonatal intensive care unit for the duration that the child is receiving care in the NICU. So now we have 12 weeks of paid leave, but then you get 12 more weeks of paid leave or until your baby is discharged from the NICU. We are the first state that has such legislation. Absolutely remarkable. And how did this come to be? Well, the co-sponsor of the bill, Senator Jeff Bridges, had a 29-week infant. He was hospitalized at Rose Medical Center. Again, personal story, personal experience informed policy at our state level. And what he will share is that it was strange to him that he and his wife were able to be at the bedside of their child nearly every day. But for other babies and other families, that was not the case. And then he started to hear stories. Well, families save their paid leave for until after the baby leaves the NICU, or they don't even really have paid leave. And so his personal story then informed his support of this legislation. And shown here is the day that the bill was signed at our state capitol. We see Senator Bridges on the left, and he actually invited a family whose infant was hospitalized right next door to their baby. And as families so often do in the NICU, they find their own community, they find their own peer supports, and create lifelong relationships and friendships. So this was when the bill was signed, and it's active January 2026. Now, I share this with you because more data will come around who will then take this leave. I have no doubt that certain populations will benefit more than others, so we really need to track that over time. But I would also call upon all of you to understand the processes that exist in your local context around how you inform families that this legislation exists. Do you have a process by which every family that enters the NICU is informed that this exists? Do you have someone that helps them complete the forms in order to get this paid leave? Many of you, I think, already do, but for those that are wondering what that workflow looks like, today is the day where you converse with each other and get ideas to ensure that access to this is truly equitable.